Burn is of two types: superficial burn and deep burn. In superficial burn, you have epidermis involved. So that's why it's a little bit painful, and it's a small area involvement usually minor lesion. It heals by 3 to 5 days. You do not need to go for the calculation of the percentage of the burn because you do not need fluid therapy admission in superficial small burn. But deep burn, they have tissue damage more, so you have epidermis and your dermis involved. You have little bit of less pain at times. At times you do not have any pain. So depending upon the nerve ending involved, nerve ending is damaged, it is involved, you have pain. If it is not, you do not have pain. So full thickness burn, since it's charred and plenty of areas involved. We know the rule of 9, head 9%, upper extremity 9, 9, trunk 9 in 2 9 in front, 2 9 on the back, lower limbs 2 9. So the perineum 1, so 99 plus 100%. In this way, you can calculate the amount of the burn. Deep burn more than 30% is really clinically important, and you need to send these children or the adult to a good center, good person. No delay. You can do a little bit of ABC, initial management of the burn. What do? You ensure the airway, breathing, and circulation. How do you ensure airway? You give you can intubate the patient, and you give oxygen, and you see you can, if there is an infection, you can give antibiotic, and distress you can give bronchodilator in the nebulized form or inhaled form if it preferably nebulized form, but don't give steroid over here because necrosis tissue and ultimate outcome of the burn will not do well with steroid. And so observe, and if it is deep, more than 30%, send and to an appropriate place. And with circulation, you ensure you secure the IV line. Ringer lactate solution can be started, and central venous line. Ultimately, you need to have it if it is more than 25% burn or so. Albumin infusion, 1 gram per kg per day. If urine output is poor, and you can catheterize the child if he doesn't have urine output or difficulties over there, and then you cool the child with not with your cold water, wrap with a dry blanket, and surgery at times is needed, but send him to an appropriate place. The plastic surgeon or then the surgeon, burn surgeon is good. Ensure the nutrition by nasogastric tube, and because the curling ulcer is common, so you can use the ACE2 blocker and PPA. There's eye care, your painkiller like IV opioids, and tetanus treatment and prophylaxis, TIG and TT, DPT, and a booster if it's not being immunized in that way. And finally, the OPD care of the burn patients is small, simple case. Most of the cases they do have small amount of burn scale commonly. Hot water is spilling into the child's body in the home. So give a little bit of saline wash, mild soap and water can be used, and wound debridement can be done, and topical antibiotic can be applied, and non-adherent dressings should be given. Silver sulfadiazine 1% can be given, and twice daily, dressing change until it is being healed. So, and local antibiotic, if you feel like a secondary infection is there, give it. TIG, as I said earlier, they should also be given, and your tetanus prophylaxis should be given.